that it shows that infertility is on the increase. And it's also interesting to know that majority of all the complaints we see in clinics, aside uterine fibroid, is actually as a result of infertility. Up to 6 to 8 out of 10 patients will complain about infertility. So what are the types of infertility? We have the primary infertility and the secondary infertility. So what primary infertility means is that primary is occurring ab initio, that is from the beginning. So primary, the couple has never been pregnant at all. They've never been pregnant. So that is primary infertility. But we call it secondary infertility when at some point the woman has been pregnant, irrespective of the location and duration of the pregnancy. Then a secondary infertility, for instance, a woman that's had maybe 2, 3 recurrent miscarriages, we'll call it secondary infertility, and now unable to get pregnant for more than 12 months, we'll call it secondary infertility. Or somebody who has had a grown-up child, maybe the child is about 8 years of age or more, and they have been trying to conceive again, they've not been able to conceive. So it's still secondary infertility. So primary infertility, there has not been any pregnancy at all. Secondary infertility, there has been pregnancy at one point or the other, irrespective of the duration or outcome of the pregnancy. So next slide, please. So what are the causes of infertility? Thankfully, in 8 out of 10 cases, we are able to find out the exact cause of infertility. And what we found out that out of the cases, 50%, 40 to 50% is due to a problem in the female, or in 30% is due to a problem in both the man and the woman, while in 20% is even only the man that has the problem. So this is important because if you look at it, that means the female and male contributes equally, because 30 plus 20, 50%. That is, in half of the cases of infertility, the male also has a role to play in this. And this is particularly important in our community, especially in Africa. Then there are some subsets that out of all the investigations, evaluating the patients, asking several questions, doing series of blood tests, even radiological investigation, we're unable to pinpoint the exact cause of the infertility. And those are the people that we term unexplained infertility. That is, we can't find a specific cause, and that's 15 to 20% of cases. Next slide, please. So for us to fully understand what causes infertility, I want to briefly introduce us to the parts of the female and male reproductive organs, because this is important for us to grasp the concept of what can make a man or the woman to come down with infertility. So this is just the basic parts in the male. So we have down here in the light blue, the testis. So the testis is the power organ, is the one that produces the spermatozoa itself. Then the one that is like a cap, the yellow one on top of it, is called the epididymis. So epididymis is necessary to mature the sperm, to give it something to be able to to develop it, to be able to move properly. So from the yellow epididymis, it passes through what we call the vas deferens. This black tube that goes all the way up. This is the vas deferens. So the vas deferens takes the spermatozoa all the way backwards. You see backwards. So this green and orange intersection. So the orange one is the seminal vesicle, while the green one is the prostate gland. They also contribute some secretions into the sperm. They gives it more volume, and that's what contributes to the semen itself. So from there, it now forms the ejaculatory duct that now moves into the penis and out during ejaculation. So this diagram is very important because we can see on top of this, just below this vas deferens, we label this bladder, which houses the urine. So it's in close proximity to the pathway that the sperm passes through during ejaculation. So sometimes, due to some problems, instead of the sperm to move forward, to go downwards through the penis, the urethra to go out, it goes backwards and goes into the urine. So next slide, please. This other diagram is just a simpler version of what I've explained earlier, telling us how the sperm moves from the testes where it's being produced to the epididymis, to the vas deferens, then all the way down to the ejaculatory duct, to the penile urethra, and out during ejaculation. Again, we can see the close relation of the bladder, which is in yellow here, to the structure. So next slide. So for the female, we have the similar homologous organs. We have a pair of ovaries on both sides, the right and left ovary. So ovary is synonymous with the testes that we find in male. So the ovary is the one that produces the eggs that joins with the sperm produced by the testes in male. So from the ovary, we have the fallopian tube, or just colloquially tube, that picks up the egg and takes it into the tube where the sperm joins with it to form the baby itself. Then it will move into the uterus. The uterus is the womb. where eventually the baby gets implanted and grows into pregnancy. So this diagram is also important because we can say that the vagina, this is where the sperm will pass through the vagina, through the cervix. Cervix is the mouth of the womb, the lowermost part of the womb or the uterus. It will pass through here, move into the tube, and join with the egg on the way, where this we call it the ampulla of the fallopian tube, where they join together to form the egg. Next slide. So the basic formation of the baby, so to say, or biologically the zygote, it involves the combination of both the sperm and the egg, that is the oocyte, that will now form the zygote, which eventually develops into the baby. So anything that can affect either of these two will definitely cause infertility. Next slide. So next slide, please. This diagram is trying to explain what I've been saying for the past few minutes, the movements of the sperm and also the movements of the egg. So anything that can affect either the production of the sperm from the testis itself or the movements through the epididymis, to the vas deferens, to the ejaculatory ducts, all those things can cause problem of infertility in the male. Likewise, anything that can affect production of the egg from the ovaries in the female, the movement through the fallopian tube, or the implantation into the uterine cavity itself can cause infertility in the female. Next. So, breaking the causes of male infertility are those that affect sperm production. That is, the sperm is not even produced at all, and the causes that affect sperm delivery. Then, for the female, the causes are also broadly divided into those that affect the egg production or the egg delivery, or those that prevent the egg that has been fertilized by the sperm to implant into the uterine cavity. Then, before I forget, I should mention here that these there are other factors that control the production of the sperm from the testes and the oocyte, that's the egg from the ovary, and we call them higher centers, specifically the hypothalamus and pituitary. They're just medical terms for some parts of the brain. So those are the ones that produce some regulatory hormones that determine how the testes or the ovary will function. So if there is any problem with all those higher centers also, you can have problem of infertility. For all those ones, I'll just mention them briefly when I'm listing the causes. They are beyond the scope of this lecture. So you can have all those other problems that are not even related to the reproductive organs in the brain. Somebody can have brain tumor and present with infertility. It is because those regulatory substances that control the testes and the ovaries to produce the sperm and the ovum respectively, they are in those higher centers, and if they are malfunctioning, definitely the ovaries and testes will also not be able to function properly. So, or broadly speaking, again, the causes of infertility. Next slide. The causes of infertility in female can be grouped into the ovarian factor. That is, those that are affecting the ovary. The woman is not even producing eggs at all. And you'll be hearing us using terms like anovulation. Anovulation means the person is not ovulating. You can have causes that target the tubal factor. That is, the woman is producing egg, the woman is ovulating, but the hair cannot move from where it's being produced to where it's going to join with the sperm. And those are the tubal factors, broadly speaking. Then we can have the uterine factor. That is, the problem is with the cavity itself, where the fertilized ovum, that's the forming baby, so to say, is supposed to implant. You can have those factors affecting that place. Then we can have what we call cervical factor. So cervical factor, like I mentioned earlier, the cervix is the mouth of the womb. And if there are some problems there, that's where the sperm will pass to go and meet with the ovum. So we can have infertility from causes affecting that. So next slide. So next slide, please. So now to the causes of male infertility. We can have the endocrine disorders, and these endocrine disorders majorly are those higher centers I mentioned earlier. We can have the problems with the hypothalamus, the pituitary. We can also have problem with the thyroid. That all these will cause something like hormonal balance also in the male, because they will make the regulatory hormones not function properly, and it will bounce back on the testes. So the testes will not produce what it's supposed to produce as it's supposed to produce it. So the one that we can relate to easily is the anatomic disorders. When I was describing the pathway of the sperm, I said it's formed in the testes, it's moved to the epididymis, to the vas deferens, to the ejaculatory duct, to the penile urethra. So any blockage along this system can cause infertility in the male. So sometimes for some unknown reasons, maybe due to chromosomal abnormalities or genetic mutation, that vas deferens, that long pipe that carries it from the epididymis, is absent in the male. It's not so common, but sometimes we can have that. So even though the testis is producing the sperm, it doesn't get transported to where it's supposed to go to. It can cause male infertility. Sometimes we can have blockage due to some tumors, some infections, chronic infections that can damage that passage, and we could have obstruction of the vas deferens. That way, the sperm will also be unable to move. Sometimes can have other abnormalities of that ejaculatory system itself, and it will make the sperm unable to move out to where it's even going to go and fertilize the ovum. Next slide. So other group of causes of male infertility include those that will cause abnormal spermatogenesis. Spermatogenesis just means formation of the spermatozoa. So we can have chromosomal abnormalities. Chromosomes are the basic genetic carrying material in the body. We all have them. So sometimes due to some mutations, these chromosomes are not normally formed, and this also affects the formation of sperm. Sometimes we can have mumps infection. I don't know how many of us speak Yoruba here, but it's called shegede in Yoruba. So a young boy that has mumps, you see that they'll present with bilateral swelling in the cheek. It usually occurs in younger age group. So especially in the boys, later on in life, it can affect the testes because during that infection, some of the virus can go into the testes and cause what we call mumps orchitis, can cause inflammation of the testes. So later in life, that kind of person can present with infertility. You can also have another cause what we call cryptorchidism. Crypto means something hidden, like cryptocurrency. So cryptorchidism means that the testis is hidden rather than it to be outside, dangling inside the scrotum, is hidden somewhere inside the abdominal cavity. Because during the development of the testis, it actually begins inside the abdomen, then it later descends and comes outside. And this is important because the inside is not meant to house the testis. Because of the differential temperature, high temperature destroys the testis itself and reduces the production of sperm. So this is a cause of male factor infertility. And also radiation. So men, due to some other problems, some may have cancers, such as bladder cancer, and they might need radiotherapy. And radiotherapy affects both normal and abnormal cells. So for somebody that's undergone radiotherapy treatment for other malignancies, other cancers, may come down with infertility later because that radiation might have destroyed the testicle. Then smoking and alcohol. I'll be specializing more on this smoking and alcohol in the subsequent slides because it also causes infertility in both male and female. So I'll be talking about this later on in life. So these abnormal motilities, sometimes the sperms are produced, but they are not moving. You see, you will hear, I'm sure you would have heard some people who say they said the sperm is not moving. So the sperm number is okay, but the sperm is not moving. So we call something cilia. Cilia are just like air-like projections that help the spermatozoa to move, usually inside the fallopian tube. So sometimes this cilia is absent. So if it's absent, it doesn't facilitate the movements of the sperm. So although the sperm is present, then it's not moving to where it's supposed to be, definitely will be infertility. We can have what we call Cartagena syndrome. It's just a big terminology similar to the absent cilia. It's just that in this Cartagena syndrome, the person will also have other complaints, recurrent chest infections, and it's also due to the absent cilia. You can have what we call varicocele. Varicocele is when you have abnormal dilatation of the blood vessels in the scrotum, specifically the pampiniform presence of veins. So all those will affect the movement of the sperm. Then we can have antibodies. Antibodies are what the body produces to fight infection generally, but sometimes due to some malfunction in the way the body is supposed to be, these antibodies are produced and they're not attacking cells. So you can have anti-sperm antibodies affecting the sperm and making them immotile. So the abnormalities in the sperm, we can have reduced sperm count, such as we call it oligospermia in the medical terms. We can have azoospermia. Azoospermia is when there is no sperm at all in the ejaculate. We can have teratozoospermia. That is when the sperms are produced, but they are abnormal looking. Then we can have astenospermia. Asteno, that means the sperm are not moving as they're supposed to move. Sorry, excuse me. So other causes of male infertility, we've talked about causes that affect the production of the sperm itself. We'll talk about causes that affect the movement of the sperm to where it's being produced. Then the third aspect, so to say, is, causes of sexual dysfunction. If the person is not having sex, so how will even if the sperm is produced 1 million, the person is not having sex, there's no how the person will be able to fertilize the oocyte. So you can have problems that can cause decreased libido in the men or even impotence. The person is unable to achieve an erection. Then sometimes you can have retrograde ejaculation. I mentioned earlier that rather than for the sperm to now move forward during ejaculation outside through the penis, it moves back into the bladder and enters and comes out through the urine. So next slide, please. So for the female, the similar classification of the causes include the central defects. And central defects is just referring to those higher centers in the brain that control the function of the ovary. So any dysfunction in them can cause the woman not to be able to produce the oocyte, that's the egg, and lead to infertility. You can have something like the hypogonadotropic anovulation, is just referring to the hypothalamus that I mentioned. You can have the pituitary itself that is not functioning well, and we can have hyperprolactinemia. This hyperprolactinemia is also something that we sometimes see in those that have polycystic ovarian syndrome, which I'll also talk about briefly shortly. So it makes the woman to be having abnormal watery or milky discharge from the breast. So it gives us an idea that the person might be having hyperprolactinemia, and it's a cause of female factor infertility. Then another cause of the infertility is the ovulatory factor. That is those that are not making the woman to ovulate. And I put here in red age and polycystic ovarian syndrome because they are a very common cause that we encounter during the gynecological clinic. You'll recall that when I was talking about causes of infertility in men, I didn't really mention age. It's not as if age does not cause some subtle decline in spermatogenesis in male, but it's not as profound as we see in female. Because for a man will continue to produce spermatozoa till he dies. They produce spermatozoa like every 3 months, they produce new spermatozoa. And the decline that you see in them is maybe due to other conditions. Maybe they have erectile dysfunction, due to other medical condition that can now cause some reduction in the fertility in them. But for a woman, the age plays an important role. This is because when a woman is born, the total number of eggs that she will have all her life, she's born with it. We don't make additional egg as we grow older. So, and this egg is about 1 million at birth, and it decreases to less than half of that as we enter puberty. Puberty is when we reach the age where we are capable of getting pregnant and carrying pregnancy. So, the total number of eggs in a woman's life is finite. We don't make additional egg, and that is why age plays a significant role in infertility in women. And you see that in women less than 30 years of age, up to 10% of them will be having infertility issue, and the incidence it increases to 15% in a woman about 30 to 35 years of age. It increases again up to 30% in those that are 35 to 40 years of age, while as high as 60% in women over 40 years of age can have infertility. And this shows the role that age plays in the fertile calendar of a woman. So another cause that is closely related to age is the premature ovarian failure. So premature ovarian failure is, we know that, no, please, previous slide. The premature ovarian failure, we know that definitely with what I explained, all of us will have ovarian failure at some point when the eggs are exhausted. So that's what we call the normal menopause. But when it's not happening earlier than expected, in a woman less than 40 years of age, that's what we call premature ovarian failure. There are other things that can make somebody to have premature ovarian failure. One of it is smoking that we'll also be talking about later. Then those that have some form of chromosomal abnormalities like Turner syndrome can have premature ovarian failure. So I put here again polycystic ovarian syndrome in red because it's also a common cause, and surprisingly, we are seeing a lot of them of recent time. This is when the woman is having some biochemical or radiological evidence of polycystic ovaries, and it manifests as menstrual irregularities. You see a lady that comes and says, I menstruate only every 3 months or every 4 months. And even when I menstruate, the blood volume is usually very scanty. You can see a lady that starts developing excessive facial hair, excessive pimples, that's acne. You understand? They do scan and they say she has polycystic ovary. So it's a very common cause of of infertility in females. So the other causes are gonadal dysgenesis and ovarian tumor. Next slide. So other causes of female infertility, they are similar to the ones I mentioned for the male. We have the thyroid disease, liver disease, renal disease. Those are obese and those that have androgen excess. Androgen is a hormone that's supposed to be in a male, and when you're not finding it more in a female, then it can cause infertility. Then a more common factor again in infertility is infection, and that's why I put it in red. Infection, it causes a high burden of infertility later in life. And the infection can range from infection not even directly related to the female reproductive tract, such as appendicitis, to the pelvic inflammatory disease that is concerning to us gynecologists. So for somebody that's been having multiple sexual partners, a recurrent vaginal infection, especially if they were not properly treated, can have infertility later in life. And this is also very important because some of those sexually transmitted infections, especially chlamydia, they might not even have any symptom the time they're having that infection. And you just be like, they did some tests or some scan and it's suggestive of PID, pelvic inflammation, and the tubes are blocked. So recurrent infection can lead to infertility. And also uterine adhesion. Uterine adhesion is just when that uterine cavity where I said the fertilized ovum is supposed to plant. Sometimes the place is narrower than it's supposed to be, or there's even no space at all. And this is what we see in Asherman syndrome. And sometimes it follows maybe somebody that had a miscarriage, for example, and maybe it was not complete, and she had to do maybe a D&C, or even D&C to even do voluntary termination of the pregnancy. And if they don't do it well, or they do it excessively, so it can lead to a complication that we call Asherman syndrome, whereby that cavity becomes sealed up. There's no space for even the oocytes to develop later in life, and that's the Asherman syndrome. You can also have endometriosis. Endometriosis is another common gynecological disorder in which the endometrial glands and stroma, that things that are supposed to be inside the womb, that endometrial cavity, you now find it abnormally in other locations in the pelvis, such as the tubes, the ovaries, and it makes the woman to be having pain. It's a very painful condition. Be having chronic pelvic pain. Somebody will just be having pain all the time, especially if it's lasting for more than 6 months and you are treating it, it's not going. So the person will have painful menses, even pain during sexual intercourse. Then we'll be thinking of endometriosis. Other causes include structural abnormalities such as Mullerian anomalies. Mullerian anomalies simply means the Mullerian ducts are just a pair of tubes that form the uterus during embryology. So the two of them come together, they fuse, then recanalize to form the uterine cavity. So sometimes you can have problems with that formation, and it may make the uterus not to fully form. So you can have the uterus that is not even it's not joined together, and the person will be looking as if the person has two uterus, double uterus, and the likes. They can also cause infertility. And I put here in red also uterine fibroid. I'll be talking more on uterine fibroid too in the next slide, because this is also something that a lot of women are concerned about. Even before they start trying to have babies, they'll be like, they did a scan and they have uterine fibroid. Does that mean I will not be able to get pregnant? So I'll expatiate more on this in the next slide. But the other factors include the acquired factors. Similarly, in males, is surgery. Maybe the person has had pelvic surgeries. Any surgery, any pelvic surgery has a risk of having adhesion. And adhesion is just abnormal joining of the structure. So with adhesion, there's a risk that the tubes will be joined together, and the head will not be able to pass, or even the sperm will not be able to pass. Radiation, again, as it damages the testes, the same applies for a woman. A woman that has undergone radiotherapy for other malignancies, other cancers, it might have damaged the ovaries and might lead to infertility. Then smoking and alcohol, again, I'll still talk about smoking and alcohol. I dedicated like a few slides for smoking and alcohol because it's very important, because there are factors that they are within our reach that we can control, and they are common causes of infertility. So next slide. So uterine fibroid and infertility. This lecture will not be complete if I don't talk about uterine fibroid and infertility. But before we go on, I want all of us to understand what uterine fibroid is. Uterine fibroid are just abnormal growth of the muscles of the uterus. So without uterus, you can't have uterine fibroid. So when you have abnormal growths, and they're not cancers, they're just abnormal benign growths of the muscles of the uterus. So there are 3 main types, although there are other subtypes, but the 3 main types, we have the intramural one, the submucosal one, and the subserous one. So if you look at the uterine fibroid like a room, and the uterus is that room, those inside the room itself, where the furniture is supposed to be, they are the submucous ones. So they are sitting inside the cavity of the uterus itself. They're inside the room. But the walls of the room, that's the wall of the uterus, the wall of the womb. If the fibroid is inside that wall, so that's the intramural fibroid. But if it's outside, that is, where you open the window outside, you can liken it to subserous fibroid. Because these 3 categorization of the types of fibroid is important when we're talking about how fibroid can cause infertility. Next slide. So the role of fibroid as causing infertility is controversial. And this is because you see there are lots of women that they will even be pregnant while having fibroid inside their uterus at the same time. So we can't fully say that fibroid causes infertility, so to say. So they've described their relationship as casual. Casual means fibroid and infertility, they are friends. So sometimes they can now be best of friends. Sometimes they can be casual friends. So in a woman that you have evaluated for all the other causes of infertility and you can't find anything except the uterine fibroid, then you can say that the uterine fibroid has a role to play in infertility, although this is still debatable. But for studies that have been done, the ones that have been shown to really affect the fertility in the woman is the submucous and the intramural type. The submucous, don't forget, is the one that is inside the cavity itself, and the intramural, the one inside the muscle of the uterus. Those are the ones that have been found to really impact on fertility negatively. While the subserous type, most studies have argued that it doesn't really contribute to infertility in the woman. So how does fibroid contribute to infertility? Sometimes because of the presence of the fibroid, it distorts the anatomy of the endometrial cavity. When you have, I don't want to use Yoruba, kongu, jaku jaku, inside the uterine cavity, distorting the anatomy of the endometrial cavity. It's difficult for the fertilized egg to even go to find a place to start to implant and start growing. So that can cause infertility. Then because of the presence of that fibroid, it makes the uterus larger. If you say a fibroid uterus and a normal uterus, usually a fibroid uterus is larger. And that increases the distance the sperm is to travel before it meets with the egg. Don't forget, the sperm will pass through the vagina to the cervix, intrauterine cavity inside the tube. So imagine it's now a lot bigger. Some of the sperm will get tired on the way, and some of them will die. Don't let me say they will commit suicide on the way and they will die. So that can contribute to infertility. Sometimes also the presence of that fibroid impairs the blood supply to the endometrial cavity because the fibroid itself needs blood to survive, and that contributes to infertility. And sometimes it can cause the uterus to be contracting anyhow. A uterus that is contracting now will not make it easy for the fertilized ovum to implant. There are also other causes, other things that can make fibroid to increase the risk of infertility. Sometimes the fibroid will be sitting just at the mouth of that womb, what I call cervix the earlier on. So if it's sitting in the cervix, there's even no way for the sperm to pass through. And likewise, sometimes the fibroid is sitting at the ostium of the fallopian tube. That's the entry of the fallopian tube. So the same way, the sperm will also not be able to pass to fertilize the ovum. Next slide. So for smoking and infertility now, smoking affects both male and female infertility. And cigarette smoke has been shown consistently that it contains hundreds of toxic substances, such as nicotine, carbon monoxide, and even substances that causes cancers, and things that can cause mutations in the body, like radioactive polonium, dimethylnitrosamine, and naphthalene. So it's a lot of toxic substances that smoke has. And sometimes I wonder why people say smoke, because aside even impacting on fertility, it is a risk factor for so many cancers. Cancer of the mouth, cancer of the throat, even cancer of the lungs. Now, aside that, it's been consistently shown that the more the person smokes, the lower the fertility rate. So smoking and infertility, they are inversely related. The more number of cigarettes the man or woman smokes, the lower their fertility rate. And in the women, it's been linked with tuberous diseases, recurrent miscarriage, and ectopic pregnancy. Ectopic pregnancy is when, instead of the pregnancy to, after joining with the sperm in the tube, to move into the uterine, that's into the womb to go and start growing, it gets stuck on the way or even stays outside the uterus itself. That's ectopic pregnancy, and it starts growing there. And because that place is not meant to carry a growing pregnancy, sometimes it's bursts, and you hear something like the person is bleeding internally because the pregnancy is in an abnormal location. That's the ectopic pregnancy. So smoking in women, it reduces the ovarian reserve. I mentioned earlier that it can cause a woman to have premature ovarian failure. Then it makes it longer for the woman to conceive. In men, it decreases the concentration of the sperm, it decreases the ability of the sperm to move, and it also makes the man to produce sperms that are abnormally formed. Then before we go to the next slide, by the time we're asking some people that do you smoke, and they say they don't smoke, we should also always remember that there's active smoking and there's passive smoking. The fact that you are not actively smoking doesn't mean that you're still not smoking. If you have a roommate that is always smoking and you're almost always with the person in the room, you are a smoker too. And in fact, it's been also shown that even those that are passive smokers, they have more risks than the person that is even smoking it actively. So it's worthy of note. Next slide. So in summary, smoking is a huge contributor to infertility. It causes low sperm counts in male. It affects the motility in the male. It even causes some hormonal problems and erectile dysfunction in the male. In the woman, it can make the woman to have premature menopause, less than 40 years of age, can cause damage to the reproductive organs, and predisposes the woman to having miscarriages or even ectopic pregnancy. Next slide. So if a couple presents to the clinic for infertility, because you see that as we've been talking, there are so many things that can make a couple to be infertile. So how do we know which one is causing which for which couple? It starts with some questions that we start asking the couple. And this is also important I mentioned, because some people will come to the clinic and be like, I've been trying to conceive for 8 years, and the doctor is asking me what type of boxers my husband is wearing, for instance. It's important. It may sound silly, but all those questions are to make us, pinpoint where the problem is likely to be, so that we can narrow the investigation, at least the initial investigations that we will do, especially in this part of the world where the resources are limited. We can't tell a patient to do all the possible investigations to investigate all the causes of infertility. And we know that even insurance, almost all of us pay out of pocket. So that would be nearly impossible to do all the investigation. So those questions are very important. And when anybody presents to the clinic for infertility, it should not be like the doctor is wasting his or her time, or the doctor does not know what he or she is doing. So it starts from the history, examination, then investigation. So the investigation targets majorly the production of the sperm, like I mentioned earlier, or the egg, then the transport and implantation of the fertilized ovum. So those are where the investigation focuses on. So next. So the issue, when we see a man coming with or without his wife and complaining of fertility, so there are some basic questions that we ask first. Aside, clarifying the age, sometimes we ask for the occupation, and be like, why is this person asking for what I'm doing now? Because some occupations, such as long distance drivers, they've been shown to have increased risks of having infertility, especially those that have close contact with hot engines. I mentioned earlier that the testes was not like very hot environments, and that's why God made it to be hanging outside. And that also explains why we'll be asking for issue of what type of underwear does the man wear. And you can be like, what underwear? Why are you asking for my underwear? So people that wear leather underwear, tights and pants, they can have some form of decreased spermatogenesis. That's the formation of the sperm. So when the woman comes, we want to ask for the age, we want to ask for the occupation, the type of underwear the person wears, the type of occupation. We want to ask, okay, the sexual act itself, does it have problem with achieving erection, maintaining erection? Does it have problem with ejaculation? When it ejaculates, is the volume very small? And sometimes does it see sperm inside the urine after sexual intercourse? That would make us be thinking, okay, maybe it's the reproductive ejaculation. We want to ask the childhood that the man did he have any infection, like the moms that I mentioned earlier when he was younger, or did they have recurrent sexually transmitted infection? Has he had any surgery done in the past that might have predisposed him to having some pelvic adhesions, or he has had treatments for some cancers in the past? We know that okay, this might have affected the testes. So all this will tailor the kind of investigations that we order for the man. Next slide. So for the woman, similar history, we want to ascertain her age, because we mentioned earlier that fertility declines as the woman ages. We want to ascertain her last menstrual period. We want to find out about her menstrual pattern. For example, if the woman is saying, my menses is usually very heavy, in fact, sometimes big clots of blood, it comes out. They've even had to admit me to transfuse me during one of my menses. Then we'll be thinking, okay, does this woman have persistent uterine fibroid? Or in the contrary, the woman says, okay, my menses is usually very scanty. Sometimes I don't see my menses for 2 months. And when it comes, the volume is very slow, very low. And I've been noticing excessive hair on my chin. And we've been having recurrent pimples. Then you might be thinking, okay, does this woman have a manovulatory infertility from polycystic ovarian syndrome? Or the woman complains that, okay, since I had abortion, my menstrual flow has significantly reduced. In fact, sometimes I don't even need to use pad. It will just come as a drop. They might be thinking of Asherman. So all those questions help us to tailor the kind of investigation that we order for, and try to make us to have an insight to what likely the problem might be out of all those groups of causes. Next slide. So the basic investigations that we start with, baseline, when the couple come for infertility, abdomen pelvic scan and hormonal profile for the female, and the seminal fluid analysis for the male. Next slide. So these are the normal semen parameters that we compare to. So when the man does semen analysis, we compare it to the normal. This is what we're supposed to find in a normal semen analysis. So any deviation from that, then we know that there's a problem with the testes there, to make us want to do some further investigation to unravel the cause. Next slide. So other tests that can be done in female is what is called HSG. So HSG is just a fancy word for hysterosalpingography. Hystero is the uterus. Salpings is the tube. Graphy lies the study. So we are ingesting in contrast through the vagina to outline the cavity of the uterus and the tube. So to see whether there is any filling defects or any blockage of the tube. So it's also a very useful test for evaluating a female infertility, especially when you are suspecting some tubal factors or some uterine factors. Very useful. Then hysteroscopy, laparoscopy, there are newer techniques. Rather than doing the HSG, hysteroscopy, you are putting like a camera through the vagina to check into the womb itself to see if there's any growth, anything blocking it, or any addition inside. Laparoscopy is the one when you are using camera to check the pelvic cavity. So you are taking it through the abdomen, through the tummy, to check whether, okay, you now put dye through the vagina and see whether the tube is patent. We are checking if there's any adhesion, that's abnormal joining together of structures in the pelvis. So you are directly looking at the pelvic cavity with the aid of a camera. And the endometrial biopsy is also to confirm if the woman is ovulating. Next slide. So the other tests that can be done in men, we can assay for the hormonal assay, especially if we are seeing something like azoospermia. Sometimes you might need to do thyroid function tests. I mentioned that thyroid abnormalities can cause infertility to both in male and female. Sometimes you might need to do a urinalysis after ejaculation, especially if you are suspecting retrograde ejaculation. Then ultrasound of the testes also, this will help to detect if there's any varicocele, that's abnormal dilatation of the breast, and other maybe testicular tumors. The genetic testing and karyotype might also be necessary. Next slide. So can infertility be treated? All the talk we've been having, if we're not going to be able to treat infertility, then really what's the point? So I'm here to tell you that there's hope. There's hope for treatment both in men and in women. So for a man that is having premature ejaculation, for example, there's some behavioral modifications that can distract the man from having premature ejaculation. When it's about to ejaculate, it can, stop the stimulation. All this. Some people talk about pinching the tip of the penis. You understand the squeeze technique to think about something else. To delay having premature ejaculation. Because some people, even before they penetrate, they're already ejaculated, and if the sperm is not getting into the female reproductive tract, then they can have problem with fertility. Then there are some medications also to help with premature ejaculation. There are some delay sprays that you can spray on the tip of the penis to delay ejaculation. For varicocele, there's surgery to correct it. If there's any blockage of all those ducts that take sperm from the testes, the sperm can be directly extracted from the testes and joined with the egg of the female, what we call ICSI, that's intracytoplasmic sperm injection. Is a form of IVF. I'll mention it briefly again later. And for retrograde ejaculation, you can take the sperm from inside that urine and join it with the egg of the woman to form pregnancy, then implant the pregnancy artificially into the womb of the woman. For those that have blockage to the epididymis, there's surgery to bypass the blockage. And if there's oligospermia, there are medications to improve the sperm quantity and as well as the quality. And if there is no sperm at all, there's the option of getting sperm from another man. Although I know many African men will not like this. Next slide. So for the woman, because we know an ovulation is a very common cause, there are so many medications that can be used to encourage the ovaries to ovulate. One of these is the popular clomifene, clomid. I'm sure many of us would have heard it. Metformin, can have letrozole, and there are other medications that can also be used to enhance ovulation. Next slide. So other treatment option is IUI. IUI is intrauterine insemination. I mentioned earlier that there are some patients that will check everything. Hormonal profile is okay. She's ovulating. There's no tuber blockage. Uterus, you cannot even find what is causing the pregnancy. One of the treatment options for this kind of people is IUI. We'll take the sperm of the man, the very good sperm, and try to insert it through the cervix, that's the mouth of the womb, into the uterine cavity. Because in those that have unexplained infertility, some people have concluded that the woman, maybe some of them are producing antibodies that are fighting the sperm. So in order to bypass that factor, if you do IUI, some of them have success rates with getting pregnant with IUI. So other treatment modality is the ICSI that I mentioned earlier on. So this is just taking the sperm, you take it with the egg, you inject the sperm directly into the egg outside and now transfer it back into the womb. They will have the full-blown IVF. So the full-blown IVF with embryo transplant is just the same thing. Joining after the ICSI, you are now putting it back into the womb. Then you can have sperm donation for those that have azoospermia. You can have oocyte donation for a woman. Maybe the woman has undergone premature menopause or something. The ovaries are failed. They are not even producing any. So you can get eggs from other women, join it with the husband's sperm, and implant it into the womb. There's what we call embryo donation. You can get sperm and ovum from other person, join it together and put inside the womb. And there's also surrogacy. Surrogacy is particularly important in women that have that uterine fibroid, uterine factor. That is the womb that has problem. They are producing egg normally, their tube is functional, but for one reason or the other, maybe the womb is blocked, or some people have even had to have their womb to be removed for one reason or the other to save their life. Maybe they were bleeding during delivery, they had to remove the womb. So surrogacy is another option. Since they have functioning egg, they can harvest the egg, join it with the husband's sperm, then look for somebody else that will carry the pregnancy. That's the surrogate. But this comes with a lot of problems. There will be instances the surrogate will run away with the baby, some surrogates start demanding extra money aside from what was agreed upon. So it's quite difficult to even get somebody that is willing to carry a pregnancy for, because pregnancy is associated with a lot of risk. So surrogacy is not an easy option. Then the last option is adoption. That's as accepting fate and just adopt another child and rear as your own. Next slide. So I put here uterine transplants. So this is a novel solution to irreversible infertility due to uterine factor. So because I said surrogacy now has been coming with a lot of problems, then it's difficult for you to get surrogates. Scientists now are looking at transplanting uterus, and they've been successful, especially in animal models, in transplanting uterus. So for a woman that is maybe about to die from another cause, they can agree to have their organs donated, what they call organ donor. So they can harvest their uterus and transplant it to a woman that doesn't have uterus and can make that woman to be able to carry her own pregnancy. Next slide. And similarly, that transplant is also done for ovaries. So they're working on having to transplant somebody else's ovary. That's the organ that produces the egg from one woman to another. They are not stopping at that. They are now looking at artificial uterus. That, okay, rather than even going through the wahala of transplanting a womb, because transplanting womb is not an easy surgery. You have to join the blood vessels. You have to ensure that the organ will take and the body will not reject it. So now artificial uterus, that means the whole process of after the IVF, the baby will develop from beginning to the end outside. You can even be looking at it as baby is developing outside world. So they're still developing this. They're still under research and not fully functional yet. The artificial uterus. Next slide. So what are the consequences of infertility? I know the time is fast spent. At this point, I would have loved for anybody that has had contact with somebody that has battled with infertility, or you've heard of somebody that has battled with infertility, to just share the experience with us. Anybody, please. I've been the only one talking since. Anybody? What was the experience like?
Thank you very much, Masofa. So if anybody among the audience, if you have a personal story to share, or someone close to you that has been through some emotional turmoil, and as a result of infertility, you could just raise your hand and we'll give you a few minutes.
I don't see anybody raising. I said that we've not seen anybody with infertility. We've not heard of infertility. I'm sure we would have had one or two people that have had to battle with the whole gamut of infertility. Okay.
Okay. We have someone.
Okay.
I think the first person that raised her hand was Muibi Rafiat.
Okay.
Okay, so how many of them should we take?
You can take the three. Do we still have time, or out of time?
Yeah, we could just give them maybe 2 minutes each. So we have three people here. So if you hear Muibi Rafiat, Abdul Salam Muslimat, and Amarachi. So in that order, you have 2 minutes each. Just share your story with us. Thank you very much for participating.
Okay. Good afternoon, everyone.
Good afternoon.
Can you hear me? Okay. So I'm with Rafiat. So I experienced some infertility I'm experiencing infertility for more than 2 years plus now. So it's not easy. Despite being a health practitioner that I advise people, but now finding yourself in the shoe, just like as if Yoruba will say Atupatoma, something like that. That Yoruba adage. Have done all the investigations. Can you hear me?
Yes, I can hear you.
Yes, I've done all the required investigations, semen analysis, follicular tracking. I've done the hormonal assay. Even I had to go for surgery, laparoscopy, although they saw some fibroid, which was removed. And at least I'm 5 months post surgery now. We are still hoping for a large was a massive. It's not palatable. It's not easy. Even the emotional psychology, sometimes you just be in the room, you just be crying. You understand? And although I think I saw somewhere that I say when you have infertility, it's not that you cannot was because it may be a testing from Allah or others. At least one has tried one's best, but I think people who have those people with infertility around, they should try and contact them because some of them are depressed. They'll be like, is it because I'm not giving birth? Nobody's asking after me. Nobody cares about me. Even some people fall into depression because of that. And maybe you just hear someone dies, someone commits suicide. Some people with infertility commit suicide because of that. Thank you.
Thank you very much,
Thank you very much.
Thank you for sharing your story, and I really empathize with you because I can imagine the lots of psychological trauma you are facing, and I pray that God answers you in earnest. Sorry to hear that.
Okay, so the second person can go ahead.
Okay. Good evening, everyone.
Good evening.
Yes.
Good evening.
Absalam Muslima. I have PCOS and I've been struggling with fertility for 3 years now. Irregular periods now and then. If I look back, like from a very young age, I've had the period issue. But you know how things work. Sometimes when it's time for me to speak out, oh mom, I'm not seeing my period. Then all of a sudden it comes like it's playing with my mental head, like why? Then fast forward to after getting, even before getting married, then I had to speak to my spouse, and that was when we started, going to the hospital and all. I went for my master's. That was when I found out that I had PCOS. And ever since then, I keep taking medications to see my periods. Like for like 2 years, just only medication. Without medication, my period is not coming. Then, of course, ovulation not happening. Then I think for 4 periods without medication, the period came itself. Like it felt so nice. Like I feel like I'm that one person that I cry when I see my period because you see some people saying, oh, my period, I don't want it. Whereas I'm always looking forward for it to come down. Then maybe it's time. I've taken Clomid, I've taken Letrozole, I've done everything. My husband has gone through series of tests as well and all, but still till now, nothing. Like the last time I saw my period was before Ramadan. Up to this moment, no period. I've tried everything. The drugs are getting to me already. I don't even want to take medications again. Depression, anxiety, and so many more. Like I'm always looking for what's the next step to take and everything. Everybody around me, my siblings that got married like 2 years after me, they have kids already, and I'm here. Everybody keeps asking. It's causing a barrier between me and my spouse and everything because the house is always quiet. This was not what we envisioned, and just like what my sister just said now, it's really emotionally draining, like really emotionally draining, whereby you have to look around at what's going on. Is this my own fate? And it's just very, very draining. I wish people would talk about it more. Even the PCOS, not until I found out I had PCOS, I didn't really know much about it, just little, if not now, that I feel people are really talking up about it. It's very, people really don't talk about it. And that's it. We always focus on the infertility aspect of PCOS, whereby nobody talks about the anxiety, the stress you go through, the weakness, like so many more. I just hope and wish we could hear people talk more about it. Then maybe there was going to be encouragement, or even there will be more focused on it, because PCOS is killing a lot of women that in Africa. Like killing them in the form of being quiet because of the stigma they might go through and all those things. That's just it. I'm still hoping and wishing that inshallah, I would become a mother soon one day too. Thank you.
Thank you for sharing your story.
Thank you very much for sharing that. And hopefully, by the special grace of God, I'm sure you will have good news.
Amen.
So we're going to just take one more. I think Amarachi was among the first three. So Amarachi, you can go ahead. Just take 2 minutes to tell us about your story.
Okay, good afternoon. Can
Good
you hear me?
afternoon.
Okay,
Yes.
yes. I've not experienced, my issue is not infertility, but I just wanted to ask because you touched on the subject. I've experienced spotting for years now. So off and on, I always have appointments with gynecologists. But the last one in January told me to carry out a couple of tests and scans. So when I did it, one of the results said I had multiple uterine myoma. So I just want to confirm, is that the same thing as uterine fibroid? That's just where my question lies.
Yes, it is. Uterine myoma is a medical name. The more medical name for uterine fibroid is the same.
Okay. Thank you. That's just what I wanted to clarify.
You're welcome.
Thank you.
Okay, so we can go back to our presentation now. Sorry, we can't take more people, but like we've heard from the horse's mouth, infertility is something that is so challenging. It's so challenging, and most times the women are left to face the brunt alone, especially in Africa, where when the couple has been having difficulty in getting pregnant, it's almost always the woman's fault. People blame the woman. If you hear them giving the husband advice to even look for another wife, there's a lot of psychological torture. Some people call the woman names in front of her, behind her back, that maybe she's a witch, she has sacrificed her womb, that's why she cannot get pregnant, all sorts. So there's lots of emotional abuse, both from even sometimes the spouse and other family members. There's a lot of stigma associated with not having children, and it's not supposed to be so. These people are already facing a lot of problems. We should not add to their problem. It's not anybody's wish to not be able to have a child. So we should not stigmatize these people. But you see that a lot of stigma comes in. Some people will not invite some people to naming ceremony because the person is infertile. They'll be like, maybe she should not come and use her evil eye to kill the baby. You hear different stories, and some people they blame them. Like I said, they blame the woman most especially. That is her fault. It's probably something she has done in her past. Maybe she was promiscuous, that's why she's unable to get pregnant. Oh, definitely she has had repeated abortion. You hear all sorts. And this causes a lot of grief, a lot of depression, like somebody mentioned, that some people even kill themselves just because of this. Sometimes it leads to marital instability, lots of quarreling between the spouse, especially if the spouse believes it's solely the problem. And you'll be surprised sometimes it's even the problem with the man. And the spouse will just be, with the wife arguing. It might even lead to separation of the marriage and divorce. So it's a lot of psychological trouble, causing anger, irritability, sadness, and a lot of stress and feeling of loneliness and despair. Feeling like you can't do anything. You've lost all hope. So infertility is a serious issue, and it causes a lot of socioeconomic hardship. Like somebody also mentioned, sometimes we ask them to do a lot of tests, and these tests are not cheap. Nigeria, insurance, we don't really have a very functional insurance. They pay almost all for these tests out of pocket. So it causes a lot of socioeconomic hardship, especially for people that are not even well to do in the first instance. And even for those that are well to do, by the time you even start getting to all the other more technical treatments, IVF, even for the normal rich people, IVF is not something that exists because it's not a guarantee. You even try it, it's so expensive and sometimes it fails. Sometimes some people have to do it 1, 2, 3, 4, 5, 6, 7 times. So it causes a lot of socioeconomic hardship. Next slide. So how do we prevent infertility? While some of the prevention might be totally out of our hands, there are some things that can still be done to prevent infertility, such as prevention of medical and reproductive health problems, such as infection. We know that infection is a major cause of infertility. So sexually transmitted infection is a major cause. So those that are not ready to marry, if you cannot abstain, then try to be faithful with one partner. But the woman can be faithful to one partner, but cannot guarantee that the other partner is also faithful. So in that way, we encourage the use of condom, consistent and correct use of condoms to prevent sexually transmitted infection. Then abortion. I'll still talk about the abortion policies because it's in red down. Because post-abortal infection and abortion, by abortion here, I don't mean voluntary termination of pregnancy alone. Even miscarriage, we call it abortion so medically. There can be infection following it. Sometimes the miscarriage will not come down completely, and some products are left, and this will serve as the nidus of infection, and this can affect the future reproductive cycle later. Sometimes can have even infection following delivery of a baby. We hear of some women that they will be in labor for hours. Eventually, they have to go and do cesarean section, and later after that first baby, they cannot give birth again. Then sometimes that kind of delivery is complicated by infection that can even cause the womb to join together, causing infertility later in life. So we can also do education, provision of reproductive health education to men and women, like what the Bashir Fistula Foundation is trying to do now, which is highly commendable. Let's talk about it more. Let's stop keeping quiet and making the person feeling going through this, that the person is all alone. By the time a problem shared is a problem half solved, and by the time we start reducing the stigma, there are some people in developed countries that even choose not to have babies on their own without anything wrong with them. So you stop stigmatizing people that are not getting pregnant. It's not what they want. It's not that they inflicted it on themselves. Even if the person did abortion, it's not everybody that did abortion that is coming out with infertility. So we should stop stigmatizing. We should continue to educate ourselves about infertility. The promotion of abstinence, like I mentioned earlier, condom use, early detection and treatment of infection. Then abortion policies, I put this in red because this is also an issue, especially among younger age group. Because we know in Nigeria it's illegal to do abortion. In fact, the doctor and as well as the patient, if they catch you, you are going to go to jail. And in places where they allow abortion freely, we look at them as if they don't know what they're doing. But we are starting to see that making the abortion law restrictive, like we have in Nigeria, is not really reducing the rate of abortion. Rather, it's making people to be forced to go to where they're not supposed to procure the abortion and coming down with complication. So we should look into it. That's beyond us anyway, but abortion policies, we need to revise it and make it in such a way that people that want it, it's not as if we're promoting promiscuity, but so that they'll be able to do it in a well-controlled environment and limit complication. The provision of reproductive services like skilled birth attendants at delivery to prevent prolonged labor. The lifestyle modifications such as exercise, especially for that PCOS, sometimes if somebody comes, we advise them that even just doing minimal exercise sometimes regularize the hormone. Then quit smoking. Smoking is just bad. There's no two ways to it. Smoking is bad. Then encouraging balanced diet to prevent obesity and all. Next slide. And I put here a picture of cigarettes literally burning the baby. So cigarettes, if we're not taking anything away from this presentation, we know that smoking is bad. And it's not just you smoking alone. If you are always almost in contact with somebody that is smoking, you are as good as being a smoker yourself. In fact, you are worse off. So smoking is highly, highly bad for fertility. Next slide. So I've been saying prevention of infertility. Like I mentioned earlier, sometimes it's difficult to prevent infertility because some people might not even, there might not be any sign that, okay, I'm at risk. It's when they are trying to get pregnant that, okay, they now find out that there's some form of delay and some. So how do you start preventing when it has already occurred? So sometimes it's difficult to achieve. But for some people, especially those that have treatments for other, I mentioned people that have cancers, for instance, they need to go for radiotherapy. We know that it's a possible complication. So those kind of people, there's something they call cryopreservation. They can take their egg and freeze it and store it till after their cancer treatment, so they can join it with the sperm later on to form a baby. Then avoid delay in childbearing. We mentioned it earlier that as a woman ages, there's decline in both the number and the quality of the egg that we're producing. And that's why there's infertility in older women compared to younger women. And there's also risk of having babies with congenital abnormalities, that's abnormal babies with older age, because the eggs that are remaining are not well formed. So we should avoid delay in childbearing. Then earlier evaluation. I mentioned this at the beginning of the lecture that although we say the definition is after 12 months, but there are some instances that we should not wait till that 12 months. For instance, somebody that is 35-year-old is coming and complaining that I've been married for 6 months. It's not that the doctor should not tell the person that, oh, don't worry, wait till the next 6 months before we start trying to find out if truly you are infertile. We should start evaluating if more than 6 months in a 35-year-old. And for those above 40 years, even if the person come one day after marriage and feels like, okay, she's been trying to conceive for one day, you start evaluating her immediately. Then these vaginal lubricants, for those that are trying to conceive, some vaginal lubricants have been shown to contain things that kill the sperm, so it might be counterproductive for those that are trying to conceive. Next slide. So we've talked a little bit about this when we were talking about the challenges infertile people face. And we're not talking about the myths surrounding infertility. And one of it is contraception and infertility. Some people believe that people that use modern contraception, that they have infertility in the future. And I'm here to tell you that this is not true. When we're talking about causes of infertility, I didn't mention contraception as part of the cause. Because although for some contraception, the return to fertility varies, especially for the one they give that injectable. Some people, the return to fertility might be 1 month, 2 months, 6 months, but there's no contraception that causes permanent impairments to fertility in a woman as of today from research. And this is even corroborated. You see that I'm sure you've heard of some stories that some people were on family planning and they got pregnant. Even funny pictures of a baby coming out with the IUD, So, and when you go for contraception, we even counsel you that they have failure rates. So for it to even fail, that means you can get pregnant while using it. So definitely it doesn't cause infertility. And that's why some adolescents, they would rather go and get pregnant and do abortion rather than use family planning. And it's that abortion now that will now cause infection, that will not even predispose them to having infertility. So if you know you are not ready, it's better to be on family planning rather than have all those unwanted pregnancy and the complications of the management. Then vaccines and infertility, this is also a very common myth. Some people say that all these vaccines that they are employed from the developed country to minimize population, to make us sterile. But I'm sure if one or two people from here would have been beneficiaries of all this child immunization, and we are here, some of them still have children. Because if you look at it, if they are doing it to make us sterile, then that means we would have been seeing more people that have been collecting the vaccine not having children. So it's not true. That's also not true, because this vaccine prevents against even infections that might have even killed the baby before the baby even grows to the age of even trying to get pregnant. So that is also a myth that is not true. Another myth is that infertility is the woman's fault all the time. That is also not true. We've shown it consistently during the presentation that it can also be a man's fault, and it can be both of them in some cases. Another myth is that only women need to seek medical help for infertility. And this also stems from the belief that it's a woman's fault. This is not true. Witchcraft and evil spirits, the person that is infertile is not possessed, did not offend one great grandmother that caused the person. So this is not true. And I put this one here because this was actually somebody that told me that mother-in-law, somebody told her that the birth of a baby, that if she allows the husband to marry a new wife, that she's also going to get pregnant. Well, this is also not true. Some people after she might be a coincidence that okay, the second wife gets pregnant and she also gets pregnant. But out of all the treatment option, I didn't say marrying another spouse will solve the problem. If you don't solve the problem that is underlying, then if you marry 100 wives, it doesn't solve the problem. And it's funny sometimes, especially if the problem is with the man marries a new wife. Some women will go and have pregnancy from another man and give it to the husband, and the husband is happy that you see, I did not have problem, it's you. And sometimes even the elder wife too might look outside and go and get pregnant. You not say, it's the birth of the new wife that brought the new baby. So it's not true. If you don't solve the cause, then all this marrying a new wife is not going to take away the problem. Then some people believe that, okay, those that were masturbating or they were promiscuous, that's why they are infertile. So I'm here to say again that it's not true. It's not everybody that is battling with infertility that was promiscuous or had repeated abortion. And this also takes care of this recklessness during pregnancy or previous. But next slide. So another myth is that some people believe that, okay, after sexual intercourse, the sperm pours out of the vagina. That maybe that's why. It's normal for some parts of it. It's majorly semen that pours out of it. It's not everything that goes inside. So far as the sperm is moving, so some will still find their way to swim up and go and fertilize. So this is not a cause of infertility. Then another myth is infertility is always permanent. Although there are some people that after everything were unable to find the cause, but it's not always the same. There are a lot of people that have testimonies that become pregnant after the diagnosis of infertility. Then this one, infertility is only a concern for older adults. I'm sure after this lecture, we can see that even younger people can have infertility. It's not only a disease of the old. So we should not dismiss anybody's complaint and be like, you are too young to be complaining of infertility. Then another myth that infertility is always because of previous abortion is also not true. Fine, abortion complications can predispose to infertility, but it's not everybody that had abortion, and that's why they are infertile. And it's not even all abortion that are complicated. Some people will have repeated abortion and they'll still have children. So it's not sacrosanct, it's not written in stone. Then the last one I'll be talking about is that some people exchange having children for wealth. I mean, this is absurd. And when I heard that, I felt sad for the person that was saying that, okay, so you think a woman will subject her life just because she wants to have money? It's just not true, even if you look at it. Next slide. So in conclusion, infertility is a multifaceted issue with significant implications for the individual and society, more for the individual. So whenever we see somebody battling with infertility, we should treat them with respect and kindness and not mock them and not make jest of them and not blame them. And although advances in medical research and technology offer promising solutions and improve understanding, Addressing infertility also requires a comprehensive approach that includes emotional support, social awareness, like what we are doing now, and equitable access to care. We can move towards a future where the challenges of infertility are met with compassion, innovation, and effective solution. Thank you very much for listening.
Thank you very much, Ma, for the beautiful engagement. I don't know if I should call it a presentation, because this was more of an engagement. We were all carried along, and I'm sure everybody here learned a thing or two. Thank you once again, Ma, for taking up the time to put this together and to deliver it in such a way that we're all happy and we know we've spent the past hour fruitfully. So now we'll move to the next aspect, which is to allow participants to ask questions. However, like we've been doing previously in our previous webinars, this won't be would not take voice questions. You could just type it out in the chat box, and I will read them out to Dr. Shiru, and I'm sure she would answer them. So if you have questions, you could just type it out, type it on the chat box, and I'll read them out. Thank you very much.
Somebody is raising a hand or his hand, I'm not sure.
Okay, okay, let me read out, let me read out a question here. Are there natural ways or healthy lifestyle for me to get my period without the use of medication? So this question came from the lady who spoke earlier about having PCOS and irregular menstruation. So she's asking if there are natural ways or healthy lifestyle for her to get her period other than using medications.
Okay, I mentioned briefly that this irregular period is a common complaint in PCOS. And usually, if I one of the advice I would tell them is for those, especially for those that are obese or overweight, if they do mild exercise, up to 5 to 10% reduction in weight sometimes regularizes the menstrual period. But for those that are not overweight and they have PCOS, this doesn't really work. Also, lifestyle modifications like eating healthy, avoiding fatty food, all those works for some people, but for majority of people, it really doesn't work, and they have to use medication. And I also have to point out that if the person is not trying to get pregnant, it's not compulsory to keep using the medication. I'll just advise the person not to delay getting married or settling down or having family so they can start the other treatments. Ovulation is not the menses itself that is the problem, but the infertility that comes with that menstrual irregularity. So sometimes the natural method include exercise, diet, but it doesn't work all the time. So I must be honest. Thank you.
Thank you, Ma, for that. So if you have further questions, you can just type it out. Okay, I think we have two people raising their hands. Omobolanle, you can ask your question. Okay, Hussein, you can ask your question.
While we're waiting for people to talk, there are some comments or questions in the chat box.
Okay, yes. So I have one that said that financial support for tests to some women will go a long way. Okay, I think that's a suggestion. Then we have another question here. Do you know any good IVF hospitals you can refer us to?
This question, I will not answer it directly. You see, determining IVF is a very tricky thing. Some people will try IVF once, they'll have twins. Some people will have test cycles and nothing. So you can't really say that the best IVF, although when choosing an IVF hospital, it's better to choose those that have like a higher percentage of success rate. So I will not, because of medical ethics, be able to name any hospital so that I will not be sent to the advertising hospital. Or whenever you are choosing an IVF hospital, look at their statistics, look at their success rates with IVF. So choose the one, although they might be slightly more expensive, but it's better to go with those that have been doing it. You know, experience is the best teacher, like they say. Those that have been doing it will likely have a higher chance of making you to get pregnant with IVF than those that are just learning how to do it, so to say. So I won't really be able to name any particular hospital. I hope you understand. Thank you.
All right, thank you, Ma. So we have a question here too that said what treatment can be recommended for a person whose HSG results came out indicative of hydrosalpinx on the left fallopian tube?
Okay, so usually hydrosalpinx is one of the sequelae for somebody that maybe had a complicated miscarriage or infection. So hydrosalpinx means there's accumulation of water, a fluid material in the tube. And in this case, she's saying the left, so that's only one of the tube. And this fluid is not just water alone, it's water containing some infection. So it can prevent somebody from getting pregnant. So usually what we do is tubal disconnection, like remove that tube that has the water. Or if it's both tube, we can remove the two tubes and the person definitely will now need an IVF. There are some people that have attempted to try to drain the water and all those things. The success rate is very low. So the easier and faster way is to disconnect the tube so that the fluid will not be contaminating any baby that is developing. And for the person that has one tube left, there's still high chance that the person can get pregnant with one tube. There are people that have ectopy, that I mentioned, that will have to remove one of the tube, and they will go ahead to have even 5-6 children on one tube. So they can do away with that tube that is infected and leave one tube. But in case of both tubes being infected, tubal disconnection and IVF. For those that want to say, okay, they cannot afford IVF, some of my older colleagues, they've tried to drain the fluid with very success rates. So they can drain the tube, but more proactive is to just disconnect the tube. I think I've answered that question.
Thank you very much, Ma. Yes, Ma, that's answered. So I believe those are all the questions we have for today.
No, there are other comments. At least I can read. Somebody is asking, how would you like, okay, our foundation. I think this is from the admin.
Yes.
So maybe people can drop their suggestions. Or now they can help. Then there are comments. There's comments from Kubrat Yunusa. I think we should read it out.
Okay. Okay, thank you. All right, so here's a comment from Kubrat Yunusa. She says, thank you for the explanation. The lecture is very interesting and enlightening. Infertility can drain you emotionally. Societal pressure can affect your confidence, marital issues. It can lead to depression, and it can even affect career progression and motivation generally. And it is also very expensive.
That is very true.
Absolutely. So, okay, how do you like a foundation to support women struggling with infertility / PCOS? Kindly drop suggestion. So, yeah, for this, if you have any suggestion on how we can support women struggling with infertility, so be it emotional support, psychological support, short of financial. I'm not sure if we're if we'll be able to give financial support at this stage. So just drop your suggestion. We're having a little discussion earlier, and I mentioned that I've seen some patients that have wasted years trying to treat infertility, but they've been doing it the wrong way. Either meeting people that are not professional or using local remedies. And you can imagine someone that got married at probably age 24, and maybe all she had was nipple discharge, which might suggest hyperprolactinemia, and then she goes ahead and take herbal concussion, this and that. If she does that for 7 years, 7 plus 24, she's already 31. So she would have wasted formative part of her reproductive years chasing a solution to her problem, but the solutions she's chasing are definitely not going to help her. So if that kind of person can get an advice or guidance on where to go or how to go about solving a problem, it will go a long way in helping her. So those are the kind of things that we're thinking of. So if you're interested in anything like that, or you know anybody who is interested, you could just let us know, and we'll put something together to help.
There are other questions in the
Okay,
chat
so
box.
we have a comment here that says emotional support would go a long way. Having someone to talk to that understand what one is going through, or even just an idea. Yeah, so that's truly something that would help. We have a question that says, is there a remedy or possibility of
Sorry,
fertility?
can I just make a suggestion to what this person said? I think one of the ways the
Okay.
foundation can also help is creating maybe a support group, like a support group for women battling with infertility, where they can talk to the yes. But, I think we can look into that as the foundation. Thank you.
Thank you very much, Ma. So there's a question for Farouk Badmos. Is there a remedy or possibility of fertility for a crypto hidden course? Hello, Ma. Okay, so I'm not sure if Dr. Shiru is still with us. However, in regards to this question, depending on the age at which it is diagnosed and found, the testis, as she mentioned, the testis can only survive in cool environment, or at least an environment that is not hot as the body temperature. So if you have a testis that is lodged inside the body for too long, mostly after the first few years of life, the testis would not be able to function anymore. So ideally, it is important to check, like for mothers to check the scrotal sac of their babies, from time to time, to ensure that the testes are still there. So for some people, they can have undescended testes for up to 6 months, 1 year. It comes down eventually. So for anything above a year, that baby might need surgical intervention. So at that stage, it can be done, and the testes will be viable. There won't be any problem. So, but for children that are older than that, it's usually unlikely that the testes will still be viable.
Thank you, Dr. Jimo. Quick announcement, please. Please, would love to get your feedback. We just sent a survey link via the chat here. So the survey is just to get the feedback of, what you feel about the webinar. How can we do it better? And how can we progress, from here as well to support and also help women's health? Please kindly use the link on the chat. Yeah, please would love to get your feedback. Thank you very much.
So thank you very much to every single person that took our time to attend this. I hope we've been able to learn a few things about infertility and how to go about solving it, either as a form of treatment or even for those that, of course, we all hope not to be faced with it, but if there are preventive measures, part of what she mentioned that can be taken, we could all make use of them. Thank you once again for coming, and take your time to fill up the survey that has been posted in the chat session. It will be very much appreciated. And we'll be working towards creating a support group. And also, the group would also serve to guide people that need information on how to go about treatment. You can join our current WhatsApp group. From there, would communicate on how to get to the support group. Thank you very much once again. See you guys next time.